First thing you think of is line analysis, right? Yes? Just say yes.
Yes.
Line analysis on the lateral, on the ADP of the mouth, on the median, and the base posterior. Okay? But if you begin to read, but not only what BJ wrote, but Percy Ramirez, who was his spinography guy, when you look at the pictures, what was BJ doing for those x-rays? You ever see him with a magnifying glass? Did you ever see lines on those x-rays? He said he looked at a pair of spinographs for 2 hours. 2 hours. The guy's not making that crap up. I know, because the doctors that I got trained by were trained by him and saw him. He would look at them, and he would see the movement. He would see how that offensive vertebra got to its insulted position and what he needed to do to unlock that. But he looked at everything. He wasn't looking just like look at the atlas. He saw everything. And you go, well, how do you know that? Because if you look at and read everything that he wrote, he talked about everything. He talked about atlas high, wedge low. All of these things came into account, but I don't think they were readily explicable in an easy fashion. I think that's where a lot of other techniques stems from, because of the difficulty of explaining something that a master does automatically. Does that kind of make sense? Oh, we're there now? Sort of? So I think a lot of the techniques came in trying to simplify what was taken for granted by these giants. So where you place the patient on the headpiece, whether it be knee posture or side posture, if we're talking in the upper cervical world, is completely contingent upon that case. Completely contingent upon the architecture that they start with. What are their condyles doing? Is one steep and one shallow? Are they both steep? Are they both shallow? Is one higher than the other? Is one twisted? Are they here in a more normal fashion? Are they out of place? Is the lower cervical a convexity on this side or a convexity on this side? Beginning to understand? All of those are going to factor into how we set them up, set the headpiece, set the stabilization, where we contact, and all of that.
I guess my question is specifically to when you have a drop headpiece, you're shearing the joint between the atlas and the occipital axis. And
That is the theory.
And so if you're not having a drop headpiece and you're in side posture, like in the knee posture, chest posture, are you now no longer shearing the joint? Do you want whatever segment you're adjusting to be backed up by the table?
No, you're always shearing the joint, no matter what. You're always, even on a gun slip, you're stabilizing, you're still shearing the joint because you're getting cleavage. You just don't have the mechanical advantage of the drop mechanism that's dropping this bowling ball and the weight of the neck. So it's just a different application of the force, but they're still both shear forces. The answer to your question is, in most of the cases, that the neck is stabilized on the headpiece, inside the headpiece work. Generally speaking. Okay.
Thank you.
You're welcome. What's your name?
Paul.
Paul.
First one.
Where you? Yeah. Where you at in your journey here?
I'm in my 10th grade graduating this year.
Ah, congratulations. Yeah.
First thing I want to say is thank you for your presentation today, because it brought me back to the essence of why I fell in love with upper cervical. Sometimes I feel like here it gets watered down, and it's just not, you breaking down the history of things, and it really motivates me to get back into the green books again, because, you know, to know where you're going, you gotta revisit the past.
Absolutely.
Question, I have something about a clarification of what you said about destructive forces.
Yeah.
So if the scan is not clear, and you adjust the person, and the scan is still not clear, was that a destructive force that you put into the body?
So that again falls into the outside stuff. So that falls into one of three possibilities. Still, so if I come here, right? That sounded awful. If I do this, the likelihood is I'm not going to cause a vertebral subluxation, right? But a force was still introduced into her body. So there's three outcomes to that force. One is that the innate intelligence of her body was able to take that force and adapt it for use. Right? That's a possibility. Second is, it's a wash. The third is that there's some damage. Maybe it did some damage to the skin, maybe it did some damage deeper, depending on how hard it hit, depending on what areas are affected. Same goes for that. When we talk about the adjusted thrust, if we have a graph that we took, we know that's their pattern. And we're taking a lot of things for granted, right? If we know that's their pattern, and we put an adjusted force, regardless of whether we hear cleavage or pop or anything, if the scan is still identical, nothing has been changed as far as the vertebral subluxation goes. Still, the force, or a part of the force that you introduced, could have been adapted for use in the body, just not use enough to correct the vertebral subluxation. Or it could be a wash, or you could have been damaged. Or a combination of the three. Does that answer your question?
So the crafting behind is that you want to be able to clear the skin so you know you put in a force that will.
Right.
That's the mastery behind it.
Right, and when you bring up a beautiful point, no insult to any technique or whatever, the comment that the next pre is the best post is the most ridiculous comment in the world, and never do that. Because, do you understand that have you heard that before?
No. I haven't.
Okay. So you're taking scans, right? You have a pre-scan, you make an adjustment, and then normally you would take a post-scan, either immediately or sometime within the time period of their visit. In my office, the average is 20 minutes, 20-minute rest period, right? Okay? Some are longer, some shorter, 20 minutes. I post-check them. That's my post-check. There are some people out there that say that, no, don't worry about that one. The best post is the next pre, so when they come in 2 days or they come in a week. My question to that is, let's say they cleared. Let's say they cleared. How do you know it was from the adjustment you gave that day or the lovemaking that he did with his wife yesterday or the falling off the swing that he was playing with his kids on this morning? Do you get that? Equally, they come in and it's pattern. You still don't know. Maybe you did clear him out. And you don't know what transpired. The same three scenarios I just gave you could have subluxated him again. But if you're doing that as your criteria, you might be not adjusting when they need to be adjusted, or adjusting when they don't need to be adjusted. You should have an immediate neurologic change if you correct the vertebral subluxation. You should have an immediate, if you understand the neurology, that stuff like cicatrix and scar tissue and not correct. Okay? If you make a chiropractic adjustment, the neurology has to manifest it. You will see that in your graphic. I'm glad you brought that up. That's a super important point. Russ.
Hi, my name is Tim, in my first quarter.
First quarter, that's so awesome that you're here.
Yeah, so I'm in my philosophy class, and in my first week, my professor told us a story of how his wife and also his kids had whooping cough, and they were suffering for almost 3 months, and he just told us the story, and at the end, they all got better from it. And I remember going home that day thinking, what would I do, and what would I think if I were in that father's position? And I think I kind of would have put myself in the same train of thought as how you would. Maybe you would check the subluxation, but at the same time, do I have to take this? Do I have to take my child to the emergency care? So my question is, if a person is subluxation free, is there a disease the person cannot adapt or recover from? And if there is, then how do you know how much that person can adapt and make the decision as a chiropractor to take emergency care.
What's a better question than that? What's a better question than that as a chiropractor? When do you refer up? What's a better question than that? Here's the question. Here's a better question. What are you telling the patient, a new patient? What is the goal of chiropractic? The goal is ultimately to get it to a state of restoration. Yes? What can it do in a state of restoration? Okay. So does that mean we live forever if we're under chiropractic care? No. So there are limitations of the matter. Very good likelihood that Mr. Tabak here can deadlift a little bit more than me. Just a little bit, I think. Why is that? Why is that? I'm a buff guy. Because of the limitations of my matter. There's only a certain amount. Now, as the chiropractor, if we know what our goal is, we know what our job is, shouldn't we transmit that to the patient as well? So is your job to cure their disease? No. Do they not come to you for a reason? Your job is to make them understand what your role is in their journey in life. And it's a chiropractic journey, not a medical journey. So the answer to your question is, I don't know of anything that the human body can't restore from. Doesn't necessarily mean they will. Does that make sense?
It makes sense. So everybody has different level of how much they can adapt with the limited matter that they're given.
What's your name?
Justine.
Justine. So I came over here and did this to Justine, right? Maybe I did it a little harder. I can do that. Hold on, you can hurt him. Else I will find me. So if I do that to him, the likelihood is I don't cause a vertebral subluxation or probably any damage at all. If I did that to his newborn baby in a day or two, do you think it would have the same?
That was my buddy Harrison.
Oh, that was Harrison. Did
I thought you were trying to date like in a
That was,
future.
yeah. He is not having a baby. Whatever I said, wipe that out.
We're good.
And he knows of at least.
Didn't know that.
Does anybody have a baby? My baby. You got a baby? How old?
16 months.
Oh, name?
Savannah.
Savannah. Oh, that's pretty good. If I did that force to forget about you. If I did that force to Savannah, do you think that it would be equally not as impactful? Or would it be more significant to Savannah, a newborn? The limitation of matter is dependent on so many factors. One is how much matter is there, the state or condition of the matter. Because if I have a vertebral subluxation that is existent in my body for years and years and years, it begins a cycle that affects the vertebral. You don't know what the vertebral is. The vertebral, which then affects every other part, which is the myomere and the neuromere and all of those other meres. The neuromere supplies everything from that vertebral, and if that has a vertebral subluxation, that means that it is out of the loop of innate intelligence control specifically. Does anybody have a volume 14 with them? I do rock. He went. Okay. Oh, look at that. Boom. Choke table. Okay. How crazy is that? Dude, you better get a steep discount for that. Okay, look at this. Huh? Did we? I'm leaving soon. Yes, thank you. Okay, what's that called? Normal complete cycle. This is one single iota in time of the perfect communication between brain cell and tissue cell. Billions and billions and billions of this are occurring all at the same time. When a vertebral subluxation occurs, something else happens. And that something else is this crazy, huh? A6. This crazy abnormal complete cycle and vertebral cycle. So what happens is we introduce a force that overwhelms. Yeah, I could be here all night. Only. This is something to be passionate about. And something that you guys need to own. And there's so much misconception out there in chiropractic. Your body, your innate does not cause a vertebral subluxation. It will never cause a vertebral subluxation. Vertebral subluxation is bad, and it occurs because of the inability of innate intelligence to adapt the force due to the limitation of matter. Think of the baby issue. Slap Jason, boom, he can handle it. Slap the baby, they can't. Limitation of matter. It's not that it's not a circuit breaker. It's not to save something worse. It's not a good thing. It's not a potential.
I just add, so you can say the limitation of matter is relative to the resistive force.
Yeah, well, no. No, because the resistive force is also innate is 100% and it's perfect, right? But it can only work in the matter in which it resides. So if the matter is weak, no matter, doesn't matter. It's the matter that causes the gap. Inability, right? And that causes the vertebral subluxation. So once you have in this cycle, once you have that normal complete cycle that was communicating well, in comes that universal force, and then what happens is we go off tangent. It's now not going through its normal process. Still has a cycle called the abnormal complete cycle in the vertebra. So all of the tissue that controls the placement of the vertebra now is whacked out. The neuromere is whacked out. It either has plus or minus function on a very simple level. So either, if it's the myomere, either the muscle is pulling too much or they're not pulling enough. If it's supplying the kidney, there's supplying too much or too much function or minus function. What's that? Okay. Wait.
One last question.
Yeah, no, wait, I'm not done yet. What was the question? The original question that started that. Were we still on your question?
So my question was, is there a disease, subluxation-free person cannot adapt to? And if there is, then when do you draw the line to say
No. The answer is no, and that wasn't, I don't know why I went off on that tangent.
But I think you
But that
answered
wasn't-
my question already.
Yeah, yeah. The idea is that's not your job. Your job is just to check for, know that you know that you can correct it, and then leave it alone and allow the body to do. If they want to go for other stuff, they can go for other stuff. You can instruct them on that. Obviously, if they pass out on your floor and like cerebral spinal fluid is pouring out of their nose, I would probably not run a scan on them. I might call 911.
Quick question?
The question is, isn't the mental impulse which arises from the brain to the body to the tissue cell, isn't it intimately dependent upon afferent signals the brain and how to interpret it and therefore what to do? Because it's a bi-directional like communication pathway.
Yeah.
So I think like, I'm not to downgrade it, but like I'm always interested in, like we need cells telling the brain where they are in space and what to do so that we know how to operate and to signal what's going on. It's kind of like it's an intimate relationship there, right? So I guess partly for me is, it's important seems to keep that circle open so things communicate, especially when brainstorming. Don't we also need clear signals coming from the joints down below?
Absolutely. And that actually brings up another point, actually a tangential point on that too. But we don't, that destructive stuff, right, universal force, we cease to exist without it. You get that? Because innate forces are only made from adapted universal forces. So we actually have to have those. We have to have that interplay. Hopefully it's a perfect interplay, right? Yes, and in fact in the art specific, our model is the mechanical receptive disaggregation model. So we work on that model. But the question is, it's almost like a chicken or egg kind of question, where does it start? But if you look at the normal complete cycle, and if we're talking about manifestation, we have to look at the universal force and the universal intelligence and where that stems and comes into the cycle. And it makes no sense that it comes into the cycle at the tissue cell. And we can go into a whole other argument about that. And the only example to use, and that would be the tissue cell in and of itself cannot function on its own without the control from above. So, one more and then
All right. My name is Steven.
Harrison from this point forward. Sorry.
So the neurocalamitors NCM was kind of the first of its kind, right, to objectify the analysis of the nervous system.
Yeah.
And it was kind of like the first shot and it worked, right? Like, holy
Rocked.
cow. And then we've developed on that and we've made it more precise.
Still a great instrument.
So, well, I'm only asking, so I've noticed a couple times as you've gone through, you've done a really good job of saying whatever technique you choose to do, or whatever set of things that you choose to do in your office, just call it what it is kind of thing. But you make a really good point of saying, if they cleared the scan, then they're good. If you made the scan, they're not.
Yeah.
Are there not any other ways to assess the nervous system, or other ways out there of, who knows, from brain scanning to, because on the scanning, you don't just scan at the location, you get distal to that as well, so is there not other things you can mention?
So the answer to that question is yes. But we have to look at, again, the whole tangent that I brought up before was, what objective test of a component of a vertebral subluxation is closest to the vertebral subluxation? And I'm not talking about proximity, just because the scan is close to that. I'm talking about what it's measuring. Are we measuring something closest to the neuronal function, so to speak? The gold standard across all health measurements is heat. And you can go into looking at the reasons why. That's for another topic of conversation. For all of chiropractic's history, and including today, that's still top on the list. As you do others, it begins to go down in validity and objectivity. Okay? Heart rate variability, can you use that? Of course you can use that. It's because here's what you want to do. Here's where philosophy meets art. Here's where philosophy meets science. What are we trying to measure? Nerve interference. What are we trying to discover? The subluxation. And what are the components of a vertebral subluxation in the classic model? MOPI, everybody heard of MOPI? Misalignment, occlusion, pressure, and interference, right? That's MOPI. The Mo part, you can see on spinographs, right? The pressure and the interference, if you have no way of monitoring that, as far as I'm concerned, you're not analyzing for vertebral subluxation. And if you're addressing that, this is why diversified is not a technique, right? So you need something that can measure. Now, mental impulse, this gentleman who just left said, it's intangible. We really don't know what it is yet. So how do you measure it? Well, how do you measure anything? I mean, electricity. Do we know where an electron is? I mean, really? No, somewhere in this freaking cloud. But we know it's there. Do we say it's not there because we can't empirically see it, taste it, or smell it yet? No. Same thing with the mental impulse. But I can see the manifestations of an electron on my studies, right? I can see the manifestations. It's the same thing with the mental impulse. If the job, what is the job of innate intelligence? Ultimately to adapt, coordination and adaptation. What does a measurement of heat do? What does pattern analysis do? Checks for adaptation. What does heart rate variability do? Checks for adaptation. Now I have tools that I can use to link me through our chiropractic philosophy back to the actual mental impulse and innate intelligence. How cool is that?
Well, I see what you mean, how you don't want to get too far away if you don't want it to be a third or fourth
Generation.
effect of it. But so obviously the heat would be in what you would think would be the closest representation of that.
That's
But
one.
I mean as far as checking the actual, because they have scans you can do from checking electrical activity, which
So-
would be direct
right.
influence of activity. And everything.
So electrical activity is now, you're talking about like
Fire, frequency
potential
of fire,
and all that kind of stuff. That's neuronal.
Okay.
That's neuronal. The mental impulse is outside of that, on top of, a carrier of. The mental impulse is not equivalent to the nerve impulse.
Well, I was just saying because the heat is the nerve. So I was just saying there.
No,
I feel like we've
no,
stopped
the heat is not the
progressing.
nerve.
But I'm not. I'm just bringing.
No, no, no.
I've had questions.
No, this is great. This is great. Everybody has the same question. The heat, the pattern we get from the heat is the result that we're looking for. It is a manifestation of adaptation. Example, if I take a scan and my scan looks like an S today, and I take it tonight and it's an S, and I take it tomorrow and it's an S, and I take it in a week and it's an S, and I take it in a month and it's an S, is it fair to say that that's static? What is the job of innate intelligence?
Adaptation.
Adaptation. Adaptation, another word for that is? Change. So if I have that, the same, all the way through, my body's not changing, it's not adapting. You see how we can connect that directly through that, the PI part of MOPI, of the vertebral subluxation? Those are the tools we have. If I take, let's just say, needle EMG, all I'm testing is the neuronal function of it. That's completely,
I was thinking more like functional MRI frequency of firing, not necessarily muscle tendency or
it's
anything.
still the same thing, because frequency of firing, we're still talking about the matter, right?
No, that helped.
Because the mental impulse is outside that, 1 foot in and 1 foot out. Cool, huh?
Yeah, I appreciate that.
You're welcome.
What point in your career did you feel like you were now at the level to pass on what you have to other people and actually teach?
I still don't even feel like I am. You know, I've had such a great experience from my mentors, true giants. Honored to have been given that. They're gone. And I felt that even though I don't know necessarily if I felt worthy to be able to, I felt that it was my responsibility to carry on their legacy so that it doesn't get lost, that it doesn't get changed, and it doesn't get sullied. That's my reason to be.
When you're talking about how when brain cross communicate positions below. How do you, and that cell cannot operate without the innervation? How does that account for things such as the beating of the heart after surgery?
Perfect. So I take that heart out, and I run with the heart. Does it beat heavier, faster? I lay down and I sleep with that heart. Does it beat slower? No. It's just its design that it has its own pacemaker in there, but it's not a neuronal control for adaptation. Only when it's under the control of the brain does it now adapt to the changes and challenges put on the body. Last question.
I had a question when I was reading, and I don't know if I was just misunderstanding something, but I was talking about like the subluxation not being permanent. like
Always
being-
there.
Yeah.
That's a really tough
And,
passage stuff.
but then it said something about like it being like locked and permanent in 3,
Three-dimensional.
and so I didn't understand the like the.
Yeah, you're gonna have to save that one, because that's a long question.
Question scans.
Quick question. We're gonna have even more all day.
I know, but. So what, is there, what do you say if someone says, well, you know, you can break apart the skin and some of it looks like the pattern, but some of it's not, or it looks like the pattern, but it is literally translated to the other side of the page. I mean, how do you know if you're saying, so if the change is a change or no?
Yes, no.
All right, so I'll see you tomorrow.
Yeah. That's such a, I mean, for everyone in the chat and listening to that, it's such a deep question. There's so much that you could read into the key patterns. I mean, literally, you could read women's menstrual cycles, you could read changes in hormones, you could read changes in activity and behavior and things like that. There's so much in it. We'll go over that.
Thank you, Dr. Reddy.